Good afternoon. We are so excited you're able to join us today. My name is Susan Evans, and I am a caregiver. My father was diagnosed with Alzheimer's disease 12 years ago, and it felt like overnight I went from being a daughter to a caregiver for both my father, concerned with the progression of his disease, and my mother, who became literally half-widowed. We kept my father at home as long as we could with caregivers and trips to adult daycare. But my father's behavior became too much for my mother, and I did not want to lose both my parents to this dreadful disease. We chose Kensington Senior Living for my father because of their expertise in memory care. He lived there 6 years, and the team took care of my father as part of their family, and my mother, who visited and had lunch with him daily. Thank you, Kensington, for the care of my family, and thank you for producing these educational webinars for the community. Today, you are in for a treat with David Hart's presentation, The Neurobiology of Change. Using Dan Signal's hand model of the brain, you will learn the neurobiology of cognitive, behavioral, and functional changes associated with each stage of dementia. We will share the questions you submitted in the registration process, but also feel free to use the Q&A function of Zoom at the conclusion of the presentation. All registrants for today's webinar will receive a copy of the webinar to share with friends and family, and you will also receive links to David Hart's website. David Hart is a clinical mental health counselor with 20 years of experience working with people with dementia and their families. Dr. Hart received his PhD in counseling from the University of Missouri, St. Louis, and was formerly the Director of Education at Alzheimer's Family Center, a state-of-the-art adult daycare center affiliated with Hoag Hospital's Neuroscience Institute. That's a sentence. Currently, Dr. Hart is Director of Community Health at Always Best Senior Services and Director of Clinical Training for the Department of Counseling at California State University, Fullerton. Dr. Hart is the founding chair of South Bay Dementia Education Consortium, is co-chair of the Orange County MFT Consortium, and has presented his published research at national and international conferences. Welcome, David, and please share a few words about Always Best Care. Thank you.
Wow, thank you for that introduction, Susan. I feel so famous.
You are. You are famous. You are famous. And based on the responses we got from the registration, everybody's very excited about the presentation today. So with that, I'm going to let David start. He has a full presentation for everybody. And to all of you that joined us, you're really in for a treat. And I'll see you for the Q&A. Take care.
That's wonderful. And also, I just need to have permission to share my screen. Is it saying that host disabled participant screen sharing? So if you could give me
We will
permission.
do that. Chris Chan will do that right now.
Okay, wonderful. Well, thank you all so much for being here. I'm also very excited to be here to talk to you about this topic. You know, it's near and dear to my heart. And I would also like to share that I'm a former family caregiver. I cared for my grandmother who had Alzheimer's disease for 8 years from the time I was 15 to 22. So that was an early life lesson for me. And I'll tell you, it was one of the hardest things that I've ever done. But it also taught me something really important about life. And that's the power, truly, the power of unconditional love for somebody. And I think back to that time and remember the lengths that I was willing to go to protect this woman that I loved so very much and to maintain her dignity. And that was something that my mom and I did together. And actually, Always Best Care Senior Services is a testament to our experience. And it's a way that we make meaning out of that experience and make meaning out of the loss of a very special matriarch in our family. And so Always Best Care Senior Services is a comprehensive senior care program that offers non-medical home care, assisted living placement. We actually partner with the Kensington and help families find them, introduce them to the Kensington and help make that connection. We also do counseling. I am a counselor, care management, particularly for patients with dementia and their families. And then we do a lot of community education, which is why I'm here with you today. So very excited to have this conversation. Now I'm going to try to share my screen here. So give me just 1 second. This is it. Share sound. Can I share sound? Okay, well, maybe we won't do that, but all right. I hope you all can see the slides, and I imagine that you can because I can. So I wanted to talk on the neurobiology of change because I have been using Dan Siegel's hand model of the brain in another workshop that I facilitate generally every month called Caregiving Essentials. And I'm going to share more about that towards the end of the presentation. But I've used Dan Siegel's hand model of the brain as a tool in teaching an addictions course at the university. I'm a professor at Cal State Fullerton, and I teach in the Department of Counseling. And so generally every semester I teach a course on addictions. And I needed a tool to help my students really understand when the brain becomes, when craving comes to power. In other words, when the craving for a substance or craving for a specific behavior like a sex addiction or gambling or something like that, that the craving becomes so intense that it essentially dysregulates self-control, right? It impairs self-control. It impairs emotional regulation, right? And so I needed something to help describe that process, and I found Dan Siegel's hand model. And if you don't know anything about Dan Siegel, he's a professor of clinical psychiatry at UCLA. He's written several best-selling books that I highly encourage you to go out and look at. I'm not connected to Dr. Siegel in any way, but his hand model has become quite popular in training clinicians on how to think about behavior change. So I've applied this hand model to working with people with dementia, and families have really responded to it. And so I wanted to share it more broadly, and here we are today. So our objectives for this afternoon, I'm going to give you an overview of what the hand model is and how it can be applied to thinking about behaviors associated with dementia as dementia progresses over 3 stages. We're not going to talk about 6 stages. We're not going to talk about 7 stages. We'll talk about 3 stages today: early stage, middle or moderate stage, and late stage dementia. And we'll be primarily focused on Alzheimer's type dementia, and I'll do a little review of that before we get started. And then I want to move into really the importance, and we talk a lot about this phrase, person-centered care, but I want to be a little bit more specific. What does that actually look like, and how can you implement it in your, caring of a loved one? And so we're going to focus on this process that we describe as attunement, emotional attunement. So I'll talk about that a little bit, and hopefully can show you something that will add a little bit of levity to this presentation. It's actually hilarious and families love it, but to give you a sense of the importance of all the different ways that we communicate, because it's not just verbal, right? We communicate cognitively, right? Sending a message is processed, and then receiving, sending a message back. Well, that's one way, right? And it's all pretty much intellectual, but we're communicating in all sorts of other ways too, and we'll talk about that. And then finally, I'll review, hopefully I get to it, in thinking about a behavioral map and understanding, we need to know the trigger or the cue for a behavior, oftentimes in order to avoid that behavior. And so a lot of this is, we think about not prevention, but mitigation. So we'll talk a little bit about that as well. All right, so some disclaimers. I'm not a medical doctor. I have a PhD in counseling. I worked very, very hard for it. So I'm an educator, I'm a researcher, and I'm a practitioner. But what that means for you is this is not going to be an MIT neurobiology class, right? This is going to be, I'm talking about a theory or a model that can be applied to thinking about dementia care. So this is just, my job is to take more complex information and sort of shrink it down in a way that's more digestible, more palatable. And that's one of the things that I love to do. So hopefully this will be a fit for you today. Okay, so let's just quickly talk about what is dementia, so we're all on the same page, because I don't know where you all are. I can't even see you, so don't know where you're coming from, what you already know, but let's just quickly define dementia. So dementia is what's described as a clinical syndrome. It's not actually a disease, right? It's a clinical syndrome, which essentially means it's a cluster of symptoms, right? So in order to be described as having dementia, the patient has to exhibit specific symptoms. And I bet you can guess what the number one symptom would be. Generally speaking, it's memory impairment, right? So you've got the memory impairment, and then you add to that impairment one or more additional cognitive impairments. And when we think about cognitive impairments, we're thinking about language. We're thinking about visual spatial orientation. We're thinking about control, self-regulation, judgment, insight, decision-making, planning. Those would be the cognitions that we're assessing for as we're trying to create this gestalt of a dementia description. So memory impairment, one or more additional cognitive impairments, and those together, those impairments will, impact the patient's activities of daily living. In other words, they're no longer able to do what they once were able to do. So for instance, my grandmother, what showed up? Short-term memory loss. How did we know? She was forgetting pots on the stove. Language was impaired, difficulty finding words, right? So that's the cognitive impairment. And then decision-making, right? Getting confused very easily about how to do something or which direction she wanted to go in. So that's the definition of dementia. Alzheimer's disease is a type or cause of dementia. So when I educate families on, when they come to see me and they say, well, what does it mean when the physician tells me that my loved one has dementia? My first question then for the physician would be, what's causing it, right? Because there are some dementias that are reversible. And I just want to quickly talk about that. It's a very small percentage, but it's one of the reasons that we really encourage families to go out and have a full diagnostic evaluation, because we want the healthcare team to be able to rule out some of these potentially reversible causes of the symptoms of dementia, right? So it could be a metabolic issue, it could be a medication side effect, it could be an internal infection like a urinary tract infection. So we want to be sure that all of that is sort of ruled out so that then we can focus on treatment for the irreversible types of dementia. And although, the treatments aren't necessarily medical at this point, right, because we have very limited pharmacological intervention, but there are other ways that we start to think about care planning for patients with all of these different types of dementia. And as I mentioned earlier, that we're going to focus primarily on the Alzheimer's type today, but you can see sort of the types. This is, in this pie graph, about 55 to 75% of all dementias, either primary or secondary diagnoses, are Alzheimer's type dementias. But you can see there that 15% is vascular dementia or mixed, about 4% is related to traumatic brain injury, and 6% is other, maybe related to alcoholism or HIV, or frontal temporal dementia. And I know many of you out there have questions, right, specific to your diagnosis. And I know there were definitely for, the Dementia Education Consortium that I'm part of, we're thinking about different educational opportunities to meet that need, because it's not all about Alzheimer's disease. And that's the vast majority of patients that have dementia. Okay. Here's the deal. As we get older, we start to experience cognitive changes, right? So it takes us longer to process information. There's more effort that's required to store information. So to learn something new, we're much more susceptible to distraction. And when I go out and talk with older adults in the community, and they're like, okay, what is the #1 strategy to help me improve my memory? And my response is to learn to pay attention better. And so focus your attention and learn to concentrate in a more intentional way. That's one strategy. And the second one is to avoid distraction. And generally they look at me like, really, that's all you got for me? And it's not typically all I have for them, but it's definitely the most important intervention if we want to sharpen our memories. So here you can see, we're not going to talk about mild cognitive impairment, but MCI is that borderland between normal aging and abnormal memory loss. But when I talk with families, and all of us, if I ask you to raise your hand, right? If I asked a question like, how many of you walk into a room and forget what you're doing there? Probably 90 to 100% of you would raise your hand. If I asked you, how many of you sometimes forget an acquaintance's name or somebody that you just recently met that you forget their name? Probably 100% of you would raise your hand. So we all know that our memory isn't as sharp as we age. But let's just take this one example. If I were to go to shop at Del Amo Fashion Plaza a couple miles from here, and I parked my car at Nordstrom, and I wanted to remember where I could find my car, I probably would really focus my attention, look for the placards on the light poles. And if I really, didn't believe that I could remember that, if I didn't have confidence that I could remember that, I might write it down. Maybe I would take a picture, okay? That's pretty normal for my age. I'm about almost 44, and I can definitely tell you that my working memory is not as efficient as it was even 5 years ago. So let's just say I might take a picture. That's normal. But the Alzheimer's patient, person with dementia, wouldn't even think to take a picture, #1, and they may be looking for their car not at Nordstrom, but at JCPenney, right? Because they've really forgotten completely where they park their car. So there are qualitative and quantitative differences, obviously. Okay, so let's talk about this neurodegenerative process in Alzheimer's disease. So you can see here this line graph, right? So we experience patients with dementia, Alzheimer's type specifically, experience cognitive decline over time. And so on average for Alzheimer's type dementia, it's 7 to 9 years. And we know that the pathological hallmarks of Alzheimer's disease, the abnormal buildup of amyloid plaque and neurofibrillary tangles, that process is beginning to happen 20 years before a patient ever exhibits a symptom of dementia, right? So we know that buildup is happening. We're just not sure what's causing it, right? That's the question that we're still trying to get to find a useful and meaningful answer. So we're experiencing, then you see over time, there's a more precipitous decline in cognitive ability. And for those of you who have loved ones with this disease, you notice that's happening. Sometimes it happens very quickly, especially for patients with frontotemporal dementia, generally speaking, and young onset Alzheimer's type dementia. It happens more rapidly, at least that's been in my experience. And for some of you, it's much, much longer, right? So diagnosis, you're noticing that there are some changes, but your loved one may stay relatively stable for a longer period of time. And you're asking, I have clients like this, you're asking questions like, is this ever going to change? Is it ever going to end? Because it just feels like it's maintaining relative consistency. So here you can see, and the brain is it's the peak of evolution, right? Enough blood vessels to go from LA to San Francisco back and forth 3 times, right? Trillions of cells, trillions upon trillions of synaptic and neuronal connections. Every breath of oxygen that you take. 40 to 50% of that oxygen goes to fuel your brain. It's a powerhouse. And everything that we do, all of who we are, is connected to this organ. And so it's so painful to watch our loved ones decline as a result of this disease, because they're not just losing their memories, right? They're losing the parts of themselves that keep them whole, their identities, who they are as people, what they've done, who they've been, what matters to them. And it doesn't mean that as a patient, declines, a person with dementia declines over time. It doesn't mean that they lose their personhood. We're holding that for them, right? All of the loved ones and the people that are involved in this person's care, we're holding that personhood for them because we're serving as their memory. But it's very, very painful to see. But here on the left, you see a healthy human brain that weighs about 3 pounds, healthy human brain tissue. On the right, you see a brain of an Alzheimer's patient at death. It loses about 2/3 of its mass over the course of the disease. And you can see at the bottom right slide there, brain tissue of a patient with Alzheimer's disease. So you can see the buildup there of the splotchy-like areas of the amyloid plaque and the other fire-like stripes of the neurofibrillary tangles. Okay. So we know that as the disease progresses, it starts in the temporal lobes, the prefrontal cortex of the brain, and then it moves into the midbrain and all the way back to the hindbrain. And this is where Dan Siegel's hand model is going to come into play. Okay, so I'm going to give you my fist here. Well, it's more than my fist, it's a hand. And I want you to imagine that this hand is, and I'll put it like similarly to what you see on your screen, right? So we've got top brain. My thumb here is going to be midbrain, and my wrist is going to be the hindbrain and the brainstem. Okay, so that sort of looks like, and let me get a little closer. Okay. So top brain, thumb is midbrain, wrist is hindbrain. Now we're going to associate top brain with early stage of dementia. Okay, so top brain is associated now with the early stage. And then the mid part of the brain here is going to be associated with the middle or moderate stage of dementia. And then the hindbrain is going to be associated with late stage dementia. So we have our 3 stages, right? Early, middle, and late. Top, middle, and hindbrain. Okay, so let's move into this. The top part of our brain, the cerebral cortex, the prefrontal cortex, is the part of the brain that makes us uniquely human in comparison to all of the other animal species on the planet. And now I'm taking you back probably to junior high science class. So the question is, what separates us as a species, human beings, from all the other animals, including the other primates, because we're also primate? So the answer is that we have language. That's what separates us from other animals on the planet, and what has created this, what has propelled us to the top of the evolutionary heap, right? Because we're able to communicate across generations and share this information. But there are other cognitive abilities that also separate us, right? And so our capacity to make decisions, to plan, to strategize, to have morals, to have spirituality, the capacity to think about thinking, right? I can literally think right now about myself talking to you and putting all of this information together in a somewhat cohesive message. judgment, right? Making judgments about what is better and not so good. Right? The ability to regulate our feelings, some level of inhibition, whether that's social inhibition or behavioral inhibition, but we have it, right? We're able to control our feelings for the most part. And there are times when the brain doesn't want us to be able to control our feelings, and we need to know about that too. Okay, so these are the cognitive abilities that make us uniquely human compared to all of the other animal species on the planet, right? So when we think about the early stage of Alzheimer's disease, you can see that as the disease starts to affect the prefrontal cortex, we're having more forgetfulness, more challenges with word finding, right? So language, visual and spatial disorientation, impaired judgment, but it's beyond just judgment, right? We're seeing that it's difficult to make decisions, difficulty planning ahead, difficulty even with, calendaring, scheduling. So there's an impairment there. And when people with dementia begin to fully experience that impairment and they continue to maintain insight and awareness, self-awareness, that you can expect that they're feeling something about that. They're feeling a loss, they're experiencing a loss, and feeling some level of despair, sadness, fear, worry, anger. And it makes sense that they would feel these feelings. You may also begin to have some suspiciousness, right, or irritability, right? Not being able to perform in the ways that we once were able to perform. It's maddening. And then there may be some level of denial, and some of you may be experiencing this in your families of origin, right? Just, I'm not willing to look at it either because that cognitive ability is completely impaired or because it's just too painful, right? Denial serves a purpose. Never underestimate the power of denial. And so functionally, you begin to see this difficulty with routine. And we're going to come back to this in a moment because routine is so important as we think about how to manage behaviors. Okay, so I'm going to go back now. So we've got this top brain, the human part of the brain, and we're associating it with the early stage. That's where we first start to see impairments. Now we're going to move down into the midbrain. It's also described as the limbic system. And this is the part of the brain that makes us uniquely mammals, right? And so there are all sorts of reasons, traits, mammalian traits that we all have as human beings. But there are some specifically that I want us to focus on today. Okay? The first one is that within this limbic system, there's a structure called the amygdala. And the amygdala is a structure that is essentially facilitates emotions. And we all have 5 primary emotions. Okay? And if you've seen the movie Inside Out, that Disney movie, you probably know what they are. But I want you to consider for a moment, if any of you have a pet at home. I happen to have a dog. My family has several dogs. I also have a cat. But my dog Coco, she's a cutie pie French bulldog. She's not here at the moment, but if she was, I would definitely show her off to you. But these 5 primary emotions are easy to see, even on her. So the 5 are joy, sadness, fear, disgust, and anger. And if you think about the suffix of emotion, right? It's emotion. So the purpose of a feeling, right? The purpose of an emotion is to generate action. It's generative. So to do something, right? So joy, to feel closeness, to celebrate. Fear, to run, right? To fight, to freeze. Anger, to advocate. Disgust, to avoid something that's not good. So that's the amygdala. So that's one structure here in the midbrain. Another structure that's very important there is the hippocampus. The hippocampus is the structure that is responsible for consolidating memory. And memories are not just about what we know. It's not just about what we know. So that's considered semantic memory. It's stuff that we learn in conversation, stuff that we learn in books, right? That's semantic memory. Memory is more than that. Memory, at its most primal level, is to help us to remember what to do more of because it feels really good, or what to do less of because it's not safe. That's critical to our survival. And the hippocampus helps to consolidate those memories, to help us to know what to do more of because it feels really good, and what to do a lot less of because it's not safe. Okay? Together, memory, right? The good stuff and the traumatic stuff, and emotions based on external stressors, right? Because that's what is happening. We're taking in information. That's unique to our mammalian experience, is that we can learn. We can learn and adapt. So when we engage the environment, we learn stuff so that we do more of something that's good and less of something that's not. That's a very elementary way of thinking about it, but it's helpful as we conceptualize working with people with dementia, because here's the deal, right? So here in this midbrain, we're experiencing emotions, we're experiencing memories, memories that are positive, memories that are negative, and those emotions and memories are, that information is streamlined into what's called the striatum. And the striatum is what propels behavior. Okay. And so typically speaking, right, I'm going to give you an example, something that I think can help you to understand this. My husband is a flight attendant, and we like to fly places because we have a benefit to do that. So we like to fly. I love to fly and I love to travel. I have to tell you, I'm extremely afraid of heights, terrified, absolutely terrified. If I see a movie and it has anything to do with somebody on a cliff, somebody on a high wire, somebody at the top of a building, somebody hanging from a helicopter, I can't even watch it because it's that terrifying for me. To close my eyes, I have to look away. I get that sick feeling in my stomach. Okay. And what is it? What's being broadcast from my midbrain? Fear. That's the emotion that's being broadcast up. Fear. So let me just give you an example. When we're flying and I'm walking down that jet bridge to the plane, my midbrain is broadcasting up fear that that plane might go down. You're going to be 36,000 feet in the air. That's way too high for you, Dave. You better get off this plane. So that's fear broadcasting information up. But what happens is my prefrontal cortex, my top brain, is holding on to that information and filtering it through my knowledge and my experiences. And what is my top brain saying to my midbrain? It's saying, Dave, you're not going to go down in this plane. It's actually safer to be on this plane than it is to be in a car. You're going to be just fine. That's what's happening with my top brain. It's also saying, Dave, chill out, man. Have a drink. Have a cocktail. You'll feel better and everything's going to be okay. But I have the capacity to do that. My cognitive ability is intact, and it can self-regulate, and it can decide, and it can reassure, and it can control all of these feelings that are being broadcast up, which is fear. Get off this plane. That sounds like a Harrison Ford quote. Yeah, Air Force One, get off my plane. Don't include that in the recording. Anyway, so that's what's happening. But let's imagine, right, that the top brain is no longer functioning, right? No self-control, no emotional regulation, no inhibition, no understanding, or limited, right? It's because we all know it fluctuates. Some days are great days, some days are not. And that depends on several different factors. So what Dan Siegel calls this is flipping the lid, that the feelings, and this is for just generally speaking, there's sometimes when we have to flip our lid, right? When the fearful feeling that we experience is like, get out of here, run and get out of here, because this isn't safe, or freeze, right? So nobody sees you. Or when you experience anger and you want to have that control, but you're feeling so angry because you have to advocate for yourself to get your needs met, right? So sometimes it's for our own survival, the lid has to be flipped. But what's happening with dementia is it's not that the lid is flipping, the lid is dissolving, it's disintegrating, right? And so what you're left with is just this mid part of the brain that is basically, essentially, responding to emotion and positive and not so positive memory cued by what's happening in the environment. Why is this important for us to understand? One is that families, generally speaking, care partners, right? They're trying to have communication that is top brain to top brain, rational, right? Conversive, focused, argumentative, right? Focused, in the here and now reality based on the care partner's perspective. And really what has to happen is we have to learn strategies to communicate from midbrain to midbrain, to communicate feeling to feeling, emotion to emotion. This requires what we describe as attunement. And I'll help you to understand how this works. When we are communicating with a little person, a child, a baby, whose prefrontal cortex is not yet fully developed, are we able to have a communication, a meaningful communication with them? And the answer is yes. We are able to have a meaningful communication with them. And how do we do that? Well, we do it in a way that I'm demonstrating now, right? We do it using our voice. We do it using our face. We do it using our eyes. We do it using our hands and our body language. And we take responsibility for the level, the kind of communication that we're having, because we know we can't expect a person without a frontal cortex, without the capability of having a full-blown conversation. We don't expect that of them. We adjust and we get down into wherever that individual is to meet them where they are. And for a little child, right, it's maybe getting down on your knees, but it's definitely changing your way of being. It's changing how you show up. So the lesson here is, right, we have to understand that the capacity to have a typical communication using conversation is starting to erode. And therefore, we have to learn strategies to have communications that are more emotionally focused, in which we take more responsibility as care partners to attune ourselves to our loved ones' needs. Why? Because we understand that the part of the brain that would do it our way is no longer functioning or is seriously impaired most days than not, or more days than not. Midbrain, middle stage. As we move into late stage and down into the brainstem, what do we expect in late stage Alzheimer's dementia, or late stage dementia generally, right? This is the reptilian part of the brain, and it's the part of the brain that's responsible mostly for automatic function, right? So everything that we don't consciously pay attention to, like our capacity to cough, our capacity to swallow, our capacity to blink our eyes, our digestive information, right? Our blood pressure, our heart rate, our respiratory rate, all of that is regulated, and we're not consciously aware that it's happening. But as the disease progresses into the late stage, those automatic functions are becoming impaired, not just impaired, they're disintegrating. And so what we see in late stage dementia are patients that are losing the capacity to walk, losing the capacity to swallow, losing the capacity for, automatic cough, blinking of the eye, all of that, skin deterioration, all of that begins to become much more of an issue. And so for my grandmother, it was aspiration, right? She wasn't able to, the swallow protocol was impaired in such a way that she was taking food into her lung, and she died from pneumonia. And so this is essentially what's happening, right? And why the hand model is so useful for most families, because they recognize that once your loved one moves into this middle stage, that there's something happening here. And we have to attend to emotion, and we also have to tend to memory, which is why we talk so much about reminiscence, right? And really having a strategy for tapping into memories that are positive. And how do we access those memories? It's not just through conversation. It's not just that way. We access memory through all sorts of stimulation, appropriate stimulation, by the way. A person living with dementia does not need to be stimulated 24 hours a day. And I know this is, probably my bias coming out. People don't need to be stimulated 24 hours a day, right? It's okay to rest. It's okay. Rest is okay. In fact, it's a critical part of our life for us to get rest. So what I'm suggesting here, though, is to, yes, have moments throughout the day, structured activities throughout the day, where we're stimulating positive memories. And that can happen through scent, it can happen through sound, it can happen through touch, it can happen through taste. But these are the ways that when we get into the middle stage, that the communication approach is shifting. It's reminiscence through multiple senses, paying attention to feeling, attuning to feeling, emotion, so that we can meet our loved ones where they are, and then avoiding triggers, right? Anything that's going to essentially cue a negative behavior, a fear-based behavior, an anger-based behavior, right? And it's not that we're going to completely eradicate that. That's not the goal. What we're trying to do is improve quality of life for person with dementia and the care partner. Now, I have no idea what time it is, but here my phone is going to tell me, oh my gosh, I just got through one thing. But I do want to just very quickly harp on this communication piece, and then we'll take questions and answers. What's so critical about shifting our communication strategy is paying attention to our way of being. And I know it's so hard for care partners. I know how frustrating it is, especially if you don't have a lot of help, especially if you're the sole person providing care and you don't get the rest that you need and the breaks that you require for your own sanity. I totally understand that. And in no way am I suggesting that care partners need to be perfect. What I am suggesting, what I'm giving you, is an invitation to consider how you show up in the majority of your interactions with your loved one. Do you show up attuned to them? In other words, meeting them where they are, having a feeling. So this is just like working with kiddos, right? We can tell when a kiddo is upset. We can tell when a kiddo is happy. We can tell when a kiddo is disgusted, when a kiddo wants to be left alone. I'm not suggesting that we treat our loved ones like kids. Please do not read between that line. I'm not suggesting that at all. What I am doing here is giving you a way of thinking about our approach to working with people. So just tuning in by paying attention to how we are responding to what our loved one is telling us, not verbally, but through how they're showing their emotions. And so that's so critical to our work. So pay attention to your nonverbals. Pay attention to your smile, your facial expressions, your eye contact, your tone of voice. Pay attention. All of that is still being processed and understood, just like it is for a little one. So I ran out of time, as I always do. It's so true, but I trust that you got something important today, something that I wanted you to get at least. I'm trusting that. I'm trusting the universe. And I hope to come back and talk with you again soon. Susan, I see you there with your fist.
It's because I don't want to lose my top half.
You don't want to flip your lid?
No, I don't want to flip my lid, but I will tell you, I went through this struggle with my father, and this information is so valuable. It becomes, I mean, this whole presentation takes the frustration out of the process and understanding the different stages. And I'm so glad that you didn't go over 6 different stages that are so confusing. You left it just to 3, you simplified it, and you gave everyone specific tools to help them. I am a huge fan, and I wish I had heard this years ago. So the audience is, you guys are so lucky. I will tell you, and your students are so fortunate. I wish I lived in Southern California and I could attend your classes, because they're the lucky ones, really.
Oh, thank you. I love to teach. Can you tell?
Well, no, you're good at it. So I'm glad you do. Educators are so incredibly respected, well respected, but this whole top brain thing, and in your example of getting on the plane, imagine losing that top and just existing day to day. It would be like being locked in a closet and living through a nightmare, because you have nothing to balance your fear or your anger or your emotion.
That's right.
That's what I used to say about my dad, is he just lost, he just didn't have any capacity to gauge himself. He had no self-regulation.
Well,
And
this is really important that you make that point, because I didn't get to this. So if our loved ones have flipped their lid, if their lid is no longer functioning, then the obvious solution to that is we become their lid, right? So how do we become their lid? Well, the most effective strategy for becoming a lid to a person with dementia is routine. Yes. Routine and structure, because the more routine we can offer our loved ones, the less confused they're going to be. And it's really in the confusion that we want to eliminate, or at least not, we can never eliminate it, but we want to moderate it in some way, because that's what creates some of these more challenging behaviors. And I could talk all day about that, but thank you for bringing up that part. But that routine is so critical. Structure, and not in an uber rigid way. And that's why, most of us are doing the scheduling and the decision making and the planning and the da-da-da-da-da. But in terms of your emotional sanity and your loved ones, so that they're not feeling like they're in jail and wondering what they're going to do, is that in that routine, make sure that it's tailored to their life, that something that gives them meaning and a sense of self. And call me, send me an email, talk to me. I'm happy to consult with you on how to do that. But there it is.
Well, and wouldn't that help the caregiver take the frustration out of their experience? I mean, it's a
Yes.
win-win. It's really a
Yes.
win-win. And a couple of things that you said is, I love that you said that the caregiver is serving as the memory as the dementia impaired individual. And that to me makes me feel good as a caregiver, that I have a purpose and that I am actually serving to assist in the memory loss of this person. You know, that takes a lot of the frustration out, I think, in caregiving. And what you said about unconditional love, you know, if you learn anything and you're a caregiver, and I know we have over 100 people on this webinar today, and next time we have you on, we will have a live webinar so you can see everybody raising their hand.
Oh, I would love that. Yeah, I would love that.
I appreciate that, but you guys are just very fortunate to have heard this. It's so valuable. A couple of questions that came in. Can trauma be a factor to progress dementia faster? And I'm going to add on to that, because I have this feeling that anesthesia can also make the disease progress faster.
Well, so I don't know what the research says about trauma, so I can't speak to that, but I would certainly say that trauma has an impact on how behaviors manifest in all people, including people with dementia, right? Because that trauma memory is going to be significant in terms of how it's, you know, triggered, how it's cued in the environment, and how it shows up. So whatever mechanism was maybe, you know, containing the effects of the trauma, now you've, you know, the lid is no longer functioning properly. It's going to have an impact, certainly. As for anesthesia, I mean, so there's not a lot of research to support that, but I think what you're suggesting is, you know, if there's a buildup, you know, let's just put it this way. Patients with Alzheimer's disease fake it really well until something happens, right, that takes them out of their routine. And hospitalization, any kind of acute illness, certainly. Both of my grandparents had dementia. Both of them, same thing happened. Anesthesia, and all of a sudden the dementia symptoms were just times exponentially pronounced. Why? Because they were taken out of their routine, taken out of their, you know, whatever processes had been containing and regulating their life, got out of whack.
And this might, Dominic just sent this question in. And first of all, this information is very valuable, and that you had mentioned that over 40% of the oxygen goes to the brain. Is there a treatment or some type of breathing exercises that we can be doing to try to oxygenate our brain better?
Absolutely. Breath is so critical to our existence.
Sometimes we forget to breathe, you know.
Yeah, we forget to breathe, and really breath is what engages our parasympathetic nervous system. And that's what helps us, right? It's one of the ways that we're able to calm down. And so any time that we can practice breath work, mindfulness, right? Giving ourselves the opportunity to de-stress. So yeah, for patients with dementia, it's, if they can, you know, it wouldn't hurt to try. If they're able to follow the instruction, let's take a deep breath in. As long as you can breathe in, let's go, we're going to do it together, right? And you can model it and then do that maybe 2 or 3 times. Absolutely. Is there research to support that it's going to shift the disease in any way? No. Can it improve quality of life? Absolutely. Absolutely.
You know, I heard that the Navy SEALs, when they're in a really stressful situation, it's called this breathing exercise, where you breathe in for 10 seconds, you hold it for 10 seconds, and you slowly breathe out for 10 seconds. And I think we can all do that daily in our lives. I mean, it sounds like a pretty easy thing.
It just requires intention.
And then Laura asked, is loss of interest in eating a part of Alzheimer's, and in what stage would this loss of interest of eating be in?
It varies, right? Every patient is individual, and so there are many factors that might go into an individual losing interest in or having an appetite. interest in food or having an appetite, but generally speaking, right, when patients start losing interest or aren't very hungry, you're getting closer to a later stage, right? You're in the middle, certainly somewhere there, and probably moving towards a later stage of the disease.
And Karen asked a question, and this, because the holidays are coming upon us, I'm sure a lot of caregivers have this question, that for people that maybe they don't have their top and you want to bring them out of their care facility for holiday meals, is it maybe better just to leave them there and visit them in their own environment?
So again, it depends. But yeah, if you have a patient that's in the moderate stage of the disease, likely it's going to create too much confusion, right? So that's one goal. One of your goals is to manage confusion. And I think meeting your loved ones where they are, right? Because they don't have the capacity to make sense of what's going on. So the more you can keep them in their routine and meet them there, I think the better for them. And likely better for you as well. But that doesn't mean that there aren't exceptions or that there aren't other perspectives on that. But generally speaking, that's the best practice.
And then there was a couple questions about depression. Like, are there different stages of depression for different types of dementias? Like depression, I saw in the early and the mid and the late, depression is kind of fluid throughout that, I think, until you don't know you're depressed because you've lost upper and middle. But is there different types of depression with different types of dementia or in the stages?
I think depression can manifest differently depending on the type of dementia. And also just the individual. I think generally speaking, you can see anger as a primary symptom, you can see irritability as a primary symptom, you can see withdrawal, right? Anhedonia, a lack of interest in activities, you can see hopelessness, right? You can see a lot of emotionality, right? I think, so there's so many factors that would affect how the depression manifests. I don't think I could speak specifically to one dementia over another. I don't have that. I don't have that knowledge or experience.
I'm sure that there's some type of dementia, as you said, associated with all different types of dementias.
Well, certainly. So as a best practice, most people with dementia and their care partners are being treated for depression, whether that's through therapy or pharmacological intervention. It just is very, very common, what we would consider a comorbidity for care partners and also for people with dementia. So I do think if you're experiencing any of those symptoms that I mentioned earlier, irritability, anger, agitation, hopelessness, anhedonia, lack of interest, lack of motivation, if you're sleeping too much or not sleeping enough, if you're eating too much or not eating enough, if you're having any thoughts at all of suicide or homicide, and take this seriously. I mean, I think for care partners especially, that is a feeling that can sometimes come up. And this is in no way to shame anybody for those feelings. It's very human reaction to human condition. But it's also an indication of, okay, maybe I need some help now, some support.
And I know in the South Bay, I think the majority of our audience is in the South Bay area of California, Redondo Beach, Manhattan. Yeah. But there is support groups. I mean, there definitely is help down there. So
lots of help.
I would encourage everybody to find help in any way. But I'm going to end it with a comment from Diane. Because I think everyone needs to be recognized that we're all doing our best as a caregiver. But Diane said this: outstanding presentation. Thank you so much. I need to make a large sheet to help me remember how to be a better caregiver for my husband. And I think we can all tell Diane that you're a caregiver for your husband. So you've accomplished a lot, and that's a real formidable challenge. And David, I'm sure you can give her some encouraging words and
yeah, I mean,
I mean, it's hard. I mean, there's nothing harder.
I think so. Be the caregiver that it's not necessarily being better. I think it's just setting intentions to be more of who you want to be. And because I don't want you to feel some sense of shame. You know, half the time these interventions don't work, and half the time they do, depending on the day and depending on all the other variables, all the other things that are happening. But trust this, you have been called to do something so profound, so life-changing, so unbelievably, it's a gift that you're giving. And it's not just a job. And so just for you accepting that calling and saying yes to being that person for your loved one, that is the best. And yes, we can do lots of things to enhance our capacity, our ability. But I want you to feel good about what you're doing.
Well, as you said, it's unconditional love.
Yeah.
Well, if you could see everybody, you're getting a standing ovation, and we can't thank you enough. And I encourage everybody, you will receive a copy of this webinar in the next few days with links to David Hart's website and access to the information. I encourage you to watch it again, and I encourage you to share this webinar with your family and loved ones. Thank you so much.
Thanks, Susan.
Take
Bye,
care.
everyone.
Have a safe evening.
Take care. Bye.